Welcome back to another lecture of Dental Pathshala, where we help you understand and learn dentistry better and easy. When this video is a continuation of the Express Revision course for oral and maxillofacial surgery, and before we get started, make sure to subscribe to the channel and hit on the bell icon so that you don't miss any of our exciting videos. You can also check out our website www.xtooth.com for more interesting notes. You can also check out the playlist of our YouTube channel for more interesting notes and for more interesting topics. So let's get started with today's topic. Today we will be covering the temporomandibular joint ankylosis. So guys, temporomandibular joint ankylosis, this is our condyle, which is a part of a mandible, which fits into the glenoid fossa. And normally what we have is the articular disc over here, which we have already covered in the anatomy of the temporomandibular joint. So in between the glenoid fossa and the condyle, we have the articular disc. Now what happens, say suppose after some kind of injury or some kind of fracture, sometimes especially in the young child, we see that there is bony union of the condyle and the glenoid fossa. So in that case, see, joint is between the two bones, and why are we able to move our mandible is the reason why is that because there is movement between the glenoid fossa and the condyle. Say suppose if this space is lost, this is the mandible, this is the glenoid fossa, the mandibular fossa, and then we have the condyle like this. If the situation is something like this, when there is a union, there is no space, there is no articular disc. Now what happens, the patient won't be able to open or close the mouth, right? Since there is no space and the joint won't be able to work properly. So in case when there is a bony union between the glenoid fossa or the mandibular fossa and the condyle, in that case the patient won't be able to work properly. I mean the opening and closing of the mouth, even anything which is involved with the opening and closing of the mouth, say speaking, eating, yawning, all these functions are affected. So that is the reason that we study TMJ ankylosis in very deep, because it is very important to treat. And sometimes, you know, after some kind of a fracture, say depressed zygomatic arch fracture, or in case of a dislocation of the condyle, or sometimes the coronoid process, if there is hypertrophy of the coronoid process or tumor of the condyle or the coronoid process, in that case also there is a pseudoankylosis. So we will be studying all the ankylosis in the today's video lecture. Now there is, say suppose if there is fracture, or say suppose if there is trauma, like if there is a forceps delivery in the child, we see that there is a union between the glenoid fossa and the condyle haad. In that case the patient won't be able to open the mouth. As you can see over here, we have removed the capsule and you can see articular disc in between the glenoid fossa and the mandibular condyle. So what if this articular capsule is injured? What if it is absent? So in that case there is going to be a bony union between both of these components. Especially we see this kind of condition in the child after trauma. So guys, say suppose if there is an intracapsular fracture in a child, or if there is a condyle displacement in the adult. So all these trauma cases leads to the true ankylosis. So we can classify ankylosis into two parts. One can be true. True means there is a true union, there is a true fusion between both of these bones. What if it is the fibrous lesion, fibrous union? So that condition we call the pseudoankylosis. That means this is not a true bony union. Instead of that, it can be due to the fibrosis of the temporalis muscle, or can be due to the myositis ossificans. So the muscles start acting like a bone, becomes very hard. Or if there is a contracture, scar contracture. So all these cases can be example for pseudo. That means it is not the bony union between both of these bony component between the glenoid fossa and the condylar head. If it is true ankylosis, that means the union is bony. That is usually because of the trauma, and especially in the children. It can be due to inflammation also in conditions like rheumatoid arthritis. Whenever there is a condition involved with the inflammation of the joint, can be Still's disease, ankylosing stomatitis, or Marie-Stemple disease, or sometimes can be due to psoriasis like psoriatic arthritis. It can be due to some post-operative complication after oral surgery. Say after a temporomandibular joint surgery, there can be union occurring between the glenoid fossa and the condylar head. So that can be due to a complication, post-operative complication of orthognathic surgery as well. So the ankylosis is basically the temporomandibular joint ankylosis is when there is a bony union present between the glenoid fossa and the condylar head. Usually what do we see, guys? Usually we see that there is articular disc which is present between both of these components. But what if there is injury to that? So in that case, the patient won't be able to open the mouth. Patient won't be able to eat properly. Not even the function is restricted. There is going to be shortening of the face, especially of the ramus side on the affected side. Say suppose if there is a unilateral ankylosis. So let me just give you a brief about the classification as well. So if it is within the capsule, so let me just show you guys the capsule over here. So guys, this is the capsule. If you can see, we have the capsule, right? So this is the capsule, and then here we have the articular disc between the glenoid fossa and the condylar head. As you can see, this blue one, slight one. So as you can see over here, this is the articular disc which is present between both of them. So if I remove it, you will be able to see it clearly. Yeah, now you can see I have removed the articular disc. So if there is any injury to the disc, so in that case also there can be bony union. That can be a true ankylosis. And since this component is fused, there is lack of this space. So what do you see is on the affected side there is going to be decreased facial height, especially at the ramal region. One more thing I would like to tell you guys is that in case of TMJ ankylosis, what do we see is, we see that there is an Antigonial Notch. So here is Antigonial Notch which is prominent, is seen in case of TMJ ankylosis. If it is unilateral, that means if one side is affected, then that means there is going to be prominent Antigonial Notch on the affected side. If both, then we see on the both the sides. So ankylosis can be intra-articular, that means within the capsule, within the joint. It can be extra-articular also because of the muscle involvement. Say suppose fibrosis of temporalis muscle. So we see that here there is temporalis muscle, right? So in case of fibrosis to ankylosis muscle, or there can be contracture, scar contracture. So all these cases there is going to be pseudoankylosis. So that also will be classified as ankylosis, but again that is extra-articular, or we can say that is a pseudoankylosis. So either it can be a bony ankylosis, it can be a fibrous ankylosis, or it can be a mixed also. And if we see the extent of fusion, extent of union, so it can be complete or it can be incomplete also. There is one more classification which is given by Topazian. So he graded this temporomandibular joint ankylosis, the complete ankylosis. So he classified or graded the complete ankylosis into 3 stages. The first one is when the ankylosis is limited to the condylar process. So if the ankylosis is limited to the condylar process, then it is grade 1. If it is limited to the extending up to the sigmoid notch, then it is 2. If it is extending up to the coronoid process, then it becomes 3. So this is according to the Topazian. So that is the staging of the complete ankylosis or the grading of the complete ankylosis. So if a person is having union between the bones, definitely there is going to be decrease in the ramal height. So if you see the face on that particular side, what do you see is that there is going to be definitely reduced chin angle, right, neck chin angle. So you will see that the chin is receded, the mandible is hypoplastic, and since the mandible, the height is shortened in that particular side, you will also see the fullness of the face. Say suppose if I am going to make a fibrosis or ankylosis in this particular side, so that means there is lack of space between the temporomandibular joint. In that case, there is going to be decreased facial height on that particular side. Say suppose if there is union on this side, so let me just show you like this, guys. Okay, say suppose if there is a union on this particular side, bony union, so that means here the face is shortened, right? This is the affected side or the ankylosed side. This one is the normal side. So what happens, since there is ankylosis, the height is shortened. If the person is trying to open the mouth, the mandible is going to shift, because here opening is normal, here opening is compromised. So chin is going to deviate to the affected side, because here the patient is able to open the mouth, here the opening is restricted. So what do we see is that on the affected side, in case of a unilateral ankylosis, there is going to be obviously facial asymmetry, right? But in case of normal, the face is going to be absolutely normal, and there is a deviation of the mandible, of the chin on the affected side, right? Also on the affected side, you will see that there is hypoplastic mandible. You will also observe there is a fullness over the face on the affected side. So this is the affected or the ankylosed side, guys. I'll just write over here, ankylosed. This one is the normal one. So you will see the hypoplastic mandible, also see the receded chin. You will also see that there is some amount of mouth opening which is seen in case of the unilateral case. But what if there is ankylosis present on both of the sides? If it is present on both of the sides, then patient won't be able to open the mouth properly to such an extent that the mouth opening is reduced to 5 millimeters or less. Sometimes we see there is nil mouth opening, there is not at all mouth opening, the patient won't be able to eat food. So he'll be opening mouth very little just to have a straw inside the mouth, that's all. So that is the reason that we have to treat the ankylosis. Since the patient is not able to open the mouth because there is a decreased mouth opening, decreased interincisal opening. So in case of, it is very much less in case of a bilateral case wherein both the sides there is union, wherein both the sides there is ankylosis. So in case of unilateral, you see that there is also cross bite, and the condylar movement will be absent in case of a unilateral ankylosis, because the condyle is not fitting into the glenoid fossa, it is not translating, since the articular disc is also absent. So in case of a unilateral ankylosis, we see that there is obviously a facial asymmetry, there is deviation of the mandible and the chin to the affected side, guys. Since this is ankylosis, this is ankylosed, so the patient won't be able to open the mouth properly. This is the normal side, you can see the patient will be able to open the mouth properly. So once the patient opens the mouth, you see that the mandible is opening on the normal side normally. On the ankylosed side, it is limited. So the mandible and the chin deviates to the affected side, which is very important point which you have to remember for viva viewpoint, for exam viewpoint, for neet, for everything. Because the deviation of the mandible and chin on the affected site, you don't have to memorize it, you just have to picturize it. Since there is ankylosis on the affected side, the mouth opening will be restricted on the same side, on the affected side, on the ankylosed side, and once the patient opens the mouth, there is a restricted mouth opening on the affected side. So what happens? The other side, the patient is able to open the mouth properly. So the mandible goes all the way to the affected side. So you will see that deviation of the mandible and the chin. On the affected side, the chin is receded, there is hypoplastic mandible, roundness and fullness over the face region. So if you see the face of the patient, the ankylosed side will become round like this. This is the normal side. So you will see the roundness or the fullness over the chin area on the affected side. On the unaffected side, you will see the elongation and the flatness of the face. So also you will find Antigonial Notch, which is present on the lower border of the mandible on the affected side in case of unilateral. In case of bilateral, there is going to be a well-defined Antigonial Notch on both of the sides. Say suppose if both of these sides are ankylosed, so that is going to be a bilateral ankylosis, right? So in case of bilateral ankylosis, the face of the person, since there is hypoplastic mandible like this, will be, there is going to be very short lower facial height, and because of that, the face of the patients looks like a bird face. That means very small mandible, hypoplastic mandible. So instead of face like this, the patient will have lower face like this. So that is the reason it looks like a bird. So we call there is a typical bird face deformity with a receded chin in case of bilateral ankylosis. Since there is a bony union between both, present in both the sides, so the patient won't be able to open the mouth. The interincisal opening, the mouth opening will be less than 5 millimeters. It can be nil also sometimes. So the mandible is symmetrical since it is present in both of the sides, but there is almost absent or can be reduced neck chin angle. There is going to be receded chin with a bird face deformity. Also, what you find is that a class 2 like malocclusion pattern. Since the mandible is receded, see guys, in the ortho what we have studied is, these are the maxillary teeth. If the maxillary teeth are way up front to the mandibular teeth, so this type of face like this is the upper lip, say, if this is the lower lip. So if this kind of facial profile we see, that is a class 2. Class 3 is when the mandible is ahead of maxilla. In case of hypoplastic maxilla, right, we see the class 3. Since the mandible is hypoplastic, mandible is small, so it looks like the maxilla is protruded. So that gives appearance of a class 2 malocclusion. We see sometimes there is a class 2 malocclusion in case of a bilateral ankylosis. The upper incisors looks very protrusive, and we also see there is an anterior open bite. Sometimes we can also see a narrow maxilla also. So there is a severe malocclusion. The patient cannot open the mouth also. So there is going to be, the whole of the mouth is very carious. There is a bad periodontal health of the patient we see. So multiple carious teeth. There can be impacted teeth we can also find in the X-ray as well. So this is the differentiating features between a bilateral ankylosis and a unilateral ankylosis. What you have to remember, the few points in the bilateral ankylosis is that there is a bird face deformity. The patient is not able to open the mouth. So there is a receded chin, there is a hypoplastic mandible, and the chin angle is also, neck chin angle is pretty much absent. It is reduced, it can be almost absent as well. There is well-defined Antigonial Notch. We can also see a class 2 like pattern, class 2 malocclusion. In case of unilateral, the most important point which you have to remember is deviation of the chin to the affected side, which is the most important point you have to remember. And also in case of bilateral ankylosis, we see that there is sometimes anterior open bite, but in case of unilateral, we see that there is a cross bite. And you can also see in unilateral case, the affected side can have a class 2 malocclusion pattern. Plus, the same side there can be a posterior cross bite also. So, the condylar movements are absent whenever there is ankylosis. So, guys, this is the main differentiating feature between a unilateral and a bilateral case. You can also check these like Antigonial Notch and all ankylosis in case of a normal plain radiograph, but always you can go for a CT scan, because in case of a post-traumatic case you will find the distance between the condyle and the glenoid fossa is reduced. So, the CT scan actually helps to determine the distance between them. Then you can also go for MRI as well. So, the most important treatment modality for a TMJ ankylosis is our gap arthroplasty. So, let me just tell you about gap arthroplasty. What do we do in case of a gap arthroplasty is, we are going to remove this condyle. Now, since we know that this condyle is fused, and the reason patient cannot open the mouth is because there is a bony union in case of true ankylosis. Now, what do we do is, we are going to relieve this bony fusion. So, that way patient will be able to open the mouth, will be able to eat properly, right. So, what we need to do is give a pre-auricular incision like this here, and then we have to remove the fascia. We have to remove the temporal fascia, we have to remove the capsule, and then we have to reach till this temporomandibular joint. We have to remove the condylar head. So, what we do is, once we give a pre-auricular incision, once we give this pre-auricular incision, we see this particular area. So, say suppose we have opened this. So, we have removed the temporal fascia, we have removed the capsule. Now, we have got the access to the condylar head and the glenoid fossa. Once you have the access to it, you are going to remove the bony chunk. So, what we do is, we make the osteotomies. We are going to remove the bone, give an incision from the burr like this, give a cut like this at the condylar, at the condylar head and at the condylar neck, and then remove this particular bone. So, now if you can see, now if you can make out, this is the glenoid fossa, guys, and here is our condyle. Now, there is no fusion. The patient can nicely open and close the mouth. Patient can nicely eat. Now, even the speech is not compromised, chewing is not compromised. Patient can also maintain the oral hygiene. So, what we do is, we create a gap, and this gap is at least 1 to 1.5 centimeters, or you can say 10 to 15 millimeters, one or the same thing, right. So, you have created a gap, and this procedure is known as gap arthroplasty. See, arthro word means joint, plasty means reshaping the joint. How are you reshaping the joint? Is by creating a gap. So, that procedure is known as gap arthroplasty. Whenever you hear of gap arthroplasty, arthro means joint. You do not have to use your brains. You can look at the word and analyze that we are talking about the temporomandibular joint. We are reshaping the temporomandibular joint. In which situation do we reshape it? When there is a fusion. We have to remove the bony union. So, how are we doing it? By creating gap, and this procedure is known as gap arthroplasty. As easy as that, right. And then we have this Caban's protocol for this. So, Caban's protocol is, the first step is same as gap arthroplasty. That means we are going to aggressively resect the ankylotic mass. Say suppose this is the ankylosis. So, what we are going to do is, we are going to remove this ankylotic mass, right. So, that is our like a gap arthroplasty. So, what we do? We are going to aggressively resect. So, that is the aggressive resection of the ankylotic mass. We are talking about Caban's protocol, guys. Ankylotic mass. So we are going to remove this ankylosis, which is the condylar head, and then what do we do is, since what happens after gap arthroplasty, there can be again ankylosis also, because there is nothing barrier, there is no barrier between the condyle and the glenoid fossa. So what happens, there can be union again happening at that particular situation. So in that case, we have to follow the Caban's protocol. So in case of we have done a gap arthroplasty, there can be reoccurrent ankylosis, there can be re-ankylosis which we see after a gap arthroplasty. That is the reason we are going for Caban's protocol. So this protocol is given by Caban, that is the reason we call it the Caban's protocol. It was given by Caban and the colleagues. So the first thing is doing the aggressive resection, and then what do? We are going to resect the coronoid process as well. Because what happens, since the condyle is not there, sometimes there can be hypertrophy of the coronoid process. So that can also lead to again the ankylosis. So that is the reason we are removing the coronoid process also. Second thing is, we remove the coronoid process and the muscle associated with that. So we go for coronoid process plus myotomy. That means myo means muscle, tomy means removal. So we remove the muscle also. First we remove the condyle, then we remove the coronoid process and the muscles on the same side. Then we remove on the opposite side also. So coronoid process and the muscles we remove on the other side, so that there is no hypertrophy. So all the things we do on the contralateral side, that means the opposite side. Guys, why this extra step? Why we are removing the coronoid process and the muscles attachment like temporalis, masseter, medial pterygoid? Why are we stripping off these muscles? Why are we dissecting these muscles? Because in case of long-standing ankylosis patient, we see that there is muscle fibrosis and there is coronoid hyperplasia. So in order to prevent that, we are already removing the coronoid process as well. So after we do the complete resection of the condyle, of the coronoid, and removing the muscles, doing the myotomy, we see the maximum mouth opening of the patient, maximum incisal opening. If it is less than 35 millimeter, then we remove the contralateral, that means the opposite side also. Then we remove the contralateral coronoidectomy. So first we do on the same side, then we check the mouth opening, and if it is less than 35 millimeters, then we go for the contralateral, that means the opposite side. Since we have removed so much of bone, so what do we observe it? The height, ramal height of the patient is pretty much less. Since the height is reduced, now it is our duty to restore the occlusion, right? So we have to reconstruct everything which we have removed. So what do? We take the temporalis fascia. This is the temporalis, this is the temporal muscle, right? Let me just, one second. Say suppose here there is temporalis muscle. We invert this temporalis muscle and then we put it in the gap which we have created, so that there is no bony union again. So we make this temporalis fascia and put it as a graft material. So interpositional graft, that means between the condyle and the glenoid fossa, we take this temporalis fascia and put it inside, place it between the both of them, so that there is no union again back. So this is to prevent the re-ankylosis. So we are going to take the temporalis fascia, and this sometimes, you know, the ramal height is so less, then we have to go for the bone graft also, because we need to increase the ramal height. Since the ramus is pretty much reduced, ramal height is very less, so we have to take a graft from 5th to 7th rib, that is the costochondral graft. We take this graft, take the bony fragment, and then rebuild the condyle again. So what we do is, we take this graft and place it like here, and then we put a mini plate over here. join it with a mini plate like this. So, we are going to restore the height. Then we fix the maxilla to the mandible, that is we do the IMF, maxillomandibular fixation, and then we are going to place a prefabricated occlusal splint. We have to maintain this fixation for 10 days and then we ask the patient to go for the physiotherapy, so that the TMJ starts working again, so that the movement starts working again. So, that was the Caban's protocol. Now, recently what we have found is the Caban's protocol has been modified. Now, previously there was a ramal and the condylar reconstruction using a costochondral graft. Instead of that, now we are using it with the distraction osteogenesis. So, in the Caban's protocol, we remove the condyle, we remove the coronoid process and the muscle attachment. We check for the maximum mouth opening. If it is less than 35 millimeter, we do the contralateral coronitectomy also. That means we remove the coronoid process on the other side also, and then we are going to rebuild it, reconstruct it, whatever is lost. So, we take the temporalis fascia, place it between the condyle and the coronoid process. So, that is going to be reconstructing like an interpositional graft, right. So, we reconstructed, we take the costochondral graft, that is the bone graft, and reconstruct the ramal height also. So, that and then we give the patient, fix it with a rigid fixation with a plate, mini plate, and then we are going to make the patient into intermaxillary fixation or maxillomandibular fixation for 10 days and then ask the patient to do the physiotherapy. This was the Caban's protocol. The modified version nowadays is that instead of costochondral graft, that is the rib graft, instead of that we are using the distraction osteogenesis technique for the ramal or the condyle reconstruction. So, that is the TMJ ankylosis. The classification is true ankylosis, pseudoankylosis based on the location. We have when it is inside the articular disc, this is intra-articular, or inside the capsule, that is intra-articular, outside it is extra-articular. Can be based on the tissue involvement, bony, fibrous or mixed, extent of the fusion. If it is complete union, we call it the complete or incomplete. So, the Topazian give the 3 stages. The first one is when it is limited to the condylar process, is the stage 1. When it reaches up till the sigmoid notch, then it is a stage 2. So, let us just mark it. So, when it is limited to the condylar process, that is stage 1. Stage 2 is when it is limited up till the sigmoid notch, then it is stage 2. Stage 3 is when the ankylosis is up till the coronoid process. So, that will be stage 3. True ankylosis, when there is a bony union, we see after a forceps delivery of a child, usually less than 10 years of age, we see the true ankylosis, say after intracapsular fracture or after the fracture. We see this true ankylosis, especially in the children. In the adult, we see after there is a medial displacement of the condylar fracture. Even after few infections, we see that there is a TMJ ankylosis, say ear infection like otitis media, or in case if there is arthritis. Arthritis is a condition which is most commonly involved with the ankylosis. So, you will see if there is rheumatoid arthritis or Still's disease, which is the version of rheumatoid arthritis in the children, ankylosing stomatitis or the Mary-Stumple disease. Again, these are all the bony joint inflammatory disorders. So, whenever there is inflammation in the joint, we see that it is associated with the TMJ ankylosis, or after a complication of TMJ surgery or after a complication of a orthognathic surgery. So, what are the situations we see? The pseudoankylosis, which is usually a fibrous ankylosis, or we can say the extra-articular. So, we are not talking about between the capsule, we are talking about outside the capsule. Say suppose if there is hypertrophy of the coronoid process, that can also lead to ankylosis, or tumor of coronoid process, or if there is after a fracture to zygomatic arch, or dislocation of the condyle, or fibrosis of temporalis muscle, or if the muscle become very stiff, like in case of myositis ossificans, the patient will also won't be able to open the mouth, so it will also be like a pseudoankylosis. So in case of ankylosis, we have covered the true and the pseudo. We see that there is a limited mouth opening, patient won't be able to open the mouth, that is the reason patient won't be able to eat or even speak properly. And if the patient is not able to open the mouth properly, if there is a limited mouth opening, the hygiene is also not maintained. Sometimes there can be possibly compromise of the airway. We also see that there is a prominent antigonial notch. So if you can see over here, this is the antigonial notch. So this particular notch is the antigonial notch. So in case of unilateral, we see on the affected side. In case of bilateral, we see on the both of the sides. There is also the shortening of the height of the ramus. So in case when there is ankylosis or true union of the bone on one side, then one side the ramal height is less, other side it is normal. So the face symmetry is lost. Also see deviation of the chin and the mandible to the affected side, which is very important point. Roundness and fullness of the face on the affected side, well defined antigonial notch on the affected side, hypoplastic mandible on the affected side, receded chin on the affected side, restricted mouth opening, cross bite, and the condylar movement is absent in case of on the affected site in case of unilateral. When both the side there is bony union of the temporomandibular joint, there is reduced mouth opening even to nil. There can be very less, close to zero mouth opening, oral opening. So the interincisal opening can be less than or equal to 5 millimeters. The patient won't be able to open the mouth. The mandible is very small, and that is the reason the face appearance of the face looks like a bird. We call it the bird face deformity. So there is a receded chin. Then the antigonial notch is well defined on both the sides, since both the sides are ankylosed. We see that there is a class 2 pattern since the mandible is short, right? So the maxillary teeth looks like the proclined maxillary teeth. So there is decreased or absent neck chin angle, anterior open bite, and multiple carious teeth. Since the patient is not able to open the mouth, we can also go for normal radiograph, CT scans or MRI. The treatment option is either we have to remove the condylar head because there is a bony union. In case of true, we are talking about, guys, and gap arthroplasty. So I have told you about gap arthroplasty. We create a gap between the joints. So we remove the condylar head, give the incision, remove the fascia, remove the capsule, and then remove the condylar head up till the neck and then suture it back. The complication is there is again chance of ankylosis since we are not creating any barrier between the gap. There is no interpositional graft. So that can occur again. So the complication is reoccurrence. There can be injury to the nerve, especially to the upper branches of the facial nerve if we are not operating properly. So there can be peripheral nerve injuries after the sequel of TMJ operations. And then there can also be perforation into the middle cranial fossa while we are removing the condyle. We can perforate it. There is loss of ramal height because we have not done reconstruction in gap arthroplasty. If we follow the Caban's protocol, we are going to do the reconstruction, right? So first one is same as the gap arthroplasty, which is we are removing the condylar head up till the neck. So we give the pre-auricular incision up till some of the part of the coronal. So we are removing the condylar head. So I have already written gap arthroplasty. Then we do the ipsilateral coronitectomy and the myotomy. So that means we are removing the coronoid process also. Then we check, because since there can be hypertrophy of the coronoid process, so in order to avoid that, there can be muscle fibrosis and coronoid hyperplasia. So in order to avoid that, we are going to remove the coronoid process as well. We check the mouth opening of the patient. If it is less than 35 millimeters, we go for the contralateral coronidectomy and the myotomy, that means the opposite side. Then we recreate it. Either what we can do is preserve the disc, place it back into its position, or we can take the autogenous interpositional graft. Most of the times we take this temporalis muscle and the fascia and then put it between the gap we have created. Or what we can do is, we can take this autogenous interposition, but mostly we take the temporalis muscle. So let's be clear about it. We take the temporalis fascia muscle and the fascia, especially the temporalis fascia. So you have to remember this, that we take the temporalis fascia and then put it between the gap we have created. Now there is not going to be a re-ankylosis, we know, because we have placed a graft between these. It is going to act as the articular disc, not exactly, but there is not going to be any fusion again back, right. So there is decreased ramal height since we have removed the condylar also, coronoid also. So in order to restore or reconstruct the occlusion back, we are going to put a costochondral graft. So that is the rib, the 5th to 7th rib, since it has got the cartilage at the end, so it will act nicely as a condyle. So we are going to put this costochondral graft. So this particular is our costochondral graft, and then we are going to fix it with a mini plate. So this is the costochondral graft, which is a rib, and fix it with a mini plate, rigid fixation. Then we are going to do the maxillomandibular fixation for at least 10 days, and after that we ask the patient to go for the physiotherapy, aggressive physiotherapy. Nowadays this Kaban protocol is modified to distraction osteogenesis. So instead of costochondral graft, now recently we started following the distraction osteogenesis. So the alloplastic material, we can also reconstruct the TMJ with some alloplastic material in case if there is ankylosis or re-ankylosis with severe abnormalities, or in case of severe inflammatory joint disorders like rheumatoid arthritis, or in case previously a autogenous bone graft has failed after having multiple operations. So that situation we can go for our alloplastic TMJ reconstruction. When we cannot go for this is when the patient is having allergy to implant graft materials, or in case patient is having uncontrolled diabetes mellitus, or an active infection at the implantation site, or if there is insufficient patient age, that means no potential for the growth. So this was about the temporomandibular joint ankylosis, when there is a union, when there is a true or bony union, we call it the true ankylosis. When it is fibrous, we call it the pseudoankylosis. So let's just go through the arthrosynthesis. So it is basically a procedure wherein we are going to wash the temporomandibular joint with a sterile fluid. Our main aim is to return the disc of the cartilage to its normal position within the joint. So what do we do in the arthroscopic technique? We are going to visualize the joint structure, and we place the arthroscope at the maximum depth we can take, and then gradually we start withdrawing. So what do we do is, we mark the L tragus line in the patient, we mark this L tragus line, say, then we go 10 millimeters ahead of this, we make a point 10 to 2 millimeters. So that means 10 millimeters on this line and 2 millimeters down below. So this is the second guys. So this is 10 millimeters, say, we go 2 millimeters beyond this. So this is the point which we use it for the arthrosynthesis. So let's just write it, guys. So this is 10 mm, this one is 2 millimeters. Take a flexible scale, we take a flexible scale and mark this point. Then we confirm the superior joint space with a vacuum after inflation, returning to the joint fluid and the mandibular motion. We ask the patient to open the mouth wide, and then what we do is, we take the syringe and then place it here like this. We do the lavage. That means, what do? We take this sterile fluid and then push it. So we push this fluid inside the joint capsule like this. Then we place another syringe over here and remove all the fluid again back. So all the fluids sweeps out from here like this. We collect this. So we are going to wash the temporomandibular joints. This is what we do in arthrosynthesis. We do the lavage of the joint. So that is lavage of the joint. We are going to clean the joint. We are going to wash the joint with a sterile fluid. So this procedure is known as arthrosynthesis. So this finishes the today's lecture. I hope that you have enjoyed the video. If you have enjoyed the video, give it a thumbs up. Also, you can comment in the comment section below. You can also check out the link provided in the description box below, or check out our website www.x2.com for the notes of this lecture and more interesting lectures. You can also support us on Patreon as well as on PayPal to make free videos for you guys and to make free notes. So till then, keep reading, keep learning, stay motivated. I'll see you soon in the next lecture.